The broadcast is now starting. All attendees are in listen-only mode.
Welcome to the New Jersey Department of Health Infection Control Assessment and Response, or ICAR, webinar. My name is Carol Janice. I'm one of the ICAR team's infection preventionists, and I will be acting as moderator for today's webinar, Infection Prevention and Control in Long-Term Care. The department's Communicable Disease Service formed the ICAR team as part of a CDC-funded initiative to assess the basics of infection prevention across the healthcare continuum. The ICAR team is comprised of 3 certified infection preventionists with backgrounds in epidemiology, microbiology, and nursing. The team performs on-site assessments using a CDC-developed setting-specific tool. We function in a non-regulatory capacity, ensuring our visits are consultative and collaborative in nature. This webinar is being held in partnership with the department's Health Facility Survey and Field Operations Division. We will address common infection prevention and control gaps identified on survey in long-term care facilities, as well as those identified through the ICAR assessments performed in 70 long-term care facilities across the state. The ICAR team has identified opportunities for improvement which closely align with common tags issued on state and federal survey. Through this collaboration, we hope to highlight common infection prevention pitfalls and share supplemental resources to strengthen overall infection prevention program and practices. Today, we will hear from Pamela Lieback of Health Facility Survey and Field Operations, the Long-Term Care Survey and Certification Program Manager, and Jessica Arias, the ICAR Team Lead and Nurse Infection Preventionist. Pamela is a registered nurse with over 25 years' experience in the acute care hospital inpatient setting in critical care. Pam holds certification as the nationally certified post-anesthesia care nurse for over 10 years. Jessica, also a registered nurse, is certified in infection prevention and control, a graduate of Wilmington University, and legislative director of the Southern New Jersey chapter of the Association for Professionals in Infection Control and Epidemiology. Before we get into the presentations, I want to talk about where we all originate organizationally. We are colleagues of the New Jersey Department of Health, but under separate arms. Pam is from Health Facility Survey and Field Operations under the Health Systems branch of the department. The ICAR team falls organizationally under the Public Health Service branch, the Epidemiology, Environmental, and Occupational Health Group. CDS is the Communicable Disease Service, the larger group under which our ICAR operates. Our roles are vastly different, but all contribute to ensuring the health and safety of New Jersey residents. And Pam will go into this furthermore later. Our agenda today is as follows. We'll review the long-term care survey process for infection prevention and control. We'll share examples of citations for infection prevention and control. And we'll compare those citations with ICAR findings from 169 assessments, 70 of which were in long-term care facilities. And we will review resources available to mitigate these citations on future surveys. We also received questions prior to recording this webinar that we will answer at the end. Thank you both for being with us here today. Pam, I'm going to turn over the microphone to you.
Thank you, Carol, for that introduction. This PowerPoint presentation is an educational tool prepared by the New Jersey Department of Health that is general in nature. It is not intended to be exhaustive review of the department's administrative code and not intended as a legal advice. Materials presented should not substitute for actual statutory or regulatory language. Always refer to the current edition of a reference statute, code and/or rule or regulation for language. Health Facility Survey and Field Operations is responsible for licensing and certification, credentialing of all healthcare facilities. We also conduct surveys and inspections to ensure the safety of patients, regulate healthcare settings, investigate complaints, and enforce compliance with state and federal guidelines. The survey process has been updated, including changes to regulatory language and interpretive guidance based on CMS or the Centers for Medicare and Medicaid Services updated Appendix PP, State Operations Manual, and Long-Term Care Survey process. With the new survey process, there are new requirements and timeframes for when information is to be received by the survey team. Information that will be requested within 4 hours from entrance within your facility will include the facility's policies and procedures for infection prevention and control, antibiotic stewardship, and influenza pneumococcal immunization. The CMS pathways are located on the website on this slide. These are helpful for healthcare facilities preparing for their surveys. Additionally, the Electronic Code of Federal Regulations, ECFR, is currently updated version of the Code of Federal Regulations, CFR. The current update status appears at the top of all ECFR web pages. For example, if you wanted to reference the CMS standards for long-term care facilities, you would refer to Title 42, Part 483.80, Infection Control. F-tags are performance metrics that measure a facility's ability to provide safe, high-quality care to residents. If these metrics are not met, it results in a citation. There are some new infection control F-tags. The new F80 regarding infection prevention and control is the old F441. F881 notes the requirement for antibiotic stewardship program. F882, infection preventist qualifications role, will be in effect November 28th of 2019 in Phase 3. F883, influenza and pneumococcal immunizations, the old F334. The regulations didn't change substantially. This was effective November 28th of 2016 and has been updated from the CDC recommendations. The vaccination should be administered routinely yearly. The resident must be assessed and offered both vaccines as it applies to the resident's immunization history, health status, and age. If facilities are addressing these top 10 areas of noncompliance, we would not expect to see these tags repeatedly cited year after year. Data from 2015 showed that F880 ranked number 3. In 2016 and 2017, it ranked number 2. Through the third quarter of 2018, F880 ranked as the number 1 cited deficiency. Clearly, improvement is necessary. Expanded guidance under F80 addresses the infection prevention and control program, surveillance and disease reporting, hand hygiene, transmission-based precautions, medical devices, and linens. In the next few slides, I want to review these in more detail. Updated regulatory language for the Infection Prevention and Control Program has added emphasis on a system for identifying and reporting of infections and communicable diseases. This program must apply to all residents, staff, volunteers, visitors, and contractors. Program policies and procedures are based upon the facility assessment and national standards. Facility policies and procedures must be developed in these areas which were not previously included in the regulatory language. F838 refers to the facility assessment. CMS intends this to be used to evaluate the facility's resident population and identify resources needed to provide necessary person-centered care and services required by facility residents. The assessment allows you to identify and prioritize your risks to plan and prevent infection control issues. F880 surveillance has been expanded to provide clarification on surveillance policies and procedures. They must be based on national standards and the facility risk assessment and include both processes and outcome measures. Ensure staff is aware of and can locate these policies and procedures. The facility must ensure that staff follows the facility's written policies and procedures, because if they don't, that's when the facility runs into trouble and deficiencies are cited. F880 also includes hand hygiene and when to use alcohol-based hand rub versus when to use soap and water. Commonly, facilities are tagged under hand hygiene because observed practice differs from written procedure. Facility procedure may specify a number of rubs, which CDC does not specify, but facilities will get tagged for failing to have staff follow the written procedure. This slide is important because it allows me to discuss the hand hygiene compliance requirements and CDC recommendations for norovirus and Colostrum difficile outbreaks, CDI. During a CDI or norovirus outbreak, or when high rates of infections are identified in the facility, hand washing with soap and water is recommended. A single case of CDI, norovirus, or during non-virus times in the facility, alcohol-based hand rub is appropriate. CMS's Life Safety Code Regulation K325 addresses the physical placement of alcohol-based hand rub dispensers and the maximum individual dispenser capacity. The dispenser should not be installed within 1 inch of an ignition source, such as an electrical outlet. There is nothing that precludes the facility from placing alcohol-based rub dispensers in convenient locations, which makes it easier for staff, visitors, and residents to comply. The facility should be aware that if through their risk assessment they identify a resident who is confused and attempts to access alcohol-based hand rub, then the facility must and needs to address that concern. Know your population by conducting a facility assessment to determine the best place to put these dispensers. Transmission-based precautions are also a component of 880. Key points include: what type of transmission-based precautions will be used and when to use them? What is the impact to the resident when being placed on isolation? And when is it appropriate to remove the resident from isolation? The goal should be to avoid unnecessary seclusion and use the least restrictive required time. Policies and procedures should be in place and include resident placement. The following should be assessed. Does the resident have a draining wound? Does the resident have loose stool? Does the resident have cognitive factors that would affect the resident's compliance with isolation precautions? Facility policies must identify the type, for instance, contact, droplet, and airborne, and the duration of the transmission-based precautions required, depending upon the infectious agent or organism involved. Furthermore, transmission-based precautions should be the least restrictive possible for the resident based on his or her clinical situation and used for the least amount of time. When used appropriately, transmission-based precautions are not to be considered involuntary seclusion. However, once the resident is no longer a risk for transmitting the infection, the duration of the illness and/or contains secretions, removing transmission-based precautions is required in order to avoid unnecessary involuntary seclusion. For example, a resident with vancomycin-resistant enterococci, VRE, who is colonized on a urine culture but is continent and cognizant, should be instructed regarding, or as necessary, assisted with performing hand hygiene before leaving his or her room, but is not placed on transmission-based precautions. For residents who are on contact precautions, consider their taking part in social activities as long as they do not have uncontained open wounds or diarrhea and are able to maintain proper hygiene. You may question, when should I put personal protective equipment on, PPE? Contact precautions are included in the interpretive guidance. PPE must be put on upon entering the patient environment, for the room or cubicle, and must be discarded before exiting. Hand hygiene must be performed. The use and discarding of PPE is included in the facility task infection control under the new survey process. Remember that in New Jersey, the universal transfer form is to be used to document communication regarding resident status, including infection prevention and control status. Part of the expansion in 880 was to include medical device safety point of care devices, such as fingerstick devices or blood glucose monitors. Fingerstick devices should never be used for more than one person. Whenever possible, blood glucose monitors should not be shared. If they must be shared, the device should be cleaned and disinfected after every use, per manufacturer's instruction. If the manufacturer does not specify how the device should be cleaned or disinfected, then it should not be shared. Please note, the FDA and CDC do not recommend using alcohol when disinfecting a glucometer, regardless of the manufacturer's recommendations. Insulin pens and other medical cartridges and syringes are for single patient use only and should never be used for more than one person. All nursing staff should know the correct cleaning and disinfection procedure, as well as the location of policies. We have had immediate jeopardy situations cited in this area for facilities that were using single patient use glucometers for multiple residents. In addition, the facility was not able to provide manufacturer instructions and were not cleaning and disinfecting the glucometers according to the manufacturer's recommendations. Now moving on to linens. How should the laundry be surveyed to assess for compliance? The answer is follow the manufacturer's instructions for use of washing machines and dryers. Use appropriate detergents. Ensure staff holds linen away from themselves, or the facility will receive a citation. Key elements of noncompliance can be failing to establish and maintain an infection prevention and control program, not reviewing annually or updating facility policies and procedures as needed, not incorporating best practice standards, not documenting surveillance, audits, or action plans, or failing to implement an antibiotic stewardship program plan. Deficiencies associated with noncompliance have severity levels ranging from level 4, immediate jeopardy, to level 1, minimal harm. I will go through examples of severity levels for deficiencies with each of the F tags I discussed. Here is an example of F880, non-compliance severity level 4, immediate jeopardy to resident health or safety. Facility staff failed to handle soiled linens using safe and sanitary techniques. A resident was observed to have acute onset of vomiting and diarrhea resulting in soiled linen and clothing. The nursing staff removed the soiled, contaminated clothing and linens, rinsed them out in a bathroom sink, and placed the wet, soiled linen on the floor. The bathroom was shared with a roommate who utilized the sink for oral hygiene purposes and stored his or her toothbrush and glass on the sink. The roommate developed vomiting and diarrhea and then subsequently severe dehydration, resulting in hospitalization. F881 includes the Antibiotic Stewardship Program, which is an important part of the Infection Prevention and Control Program. Although the infection preventist is critical to the success of the facility's Antibiotic Stewardship Program, ensure individuals with antibiotic prescribing expertise, such as a medical director, infectious disease physician, or pharmacy consultant, are available and accountable to further implement and lead this program. The purpose of the stewardship program is to ensure that residents are prescribed antibiotics that are appropriate. This means not only that there is an indication for antibiotic, but that is the correct antibiotic prescribed at the correct dose and duration. Antibiotic use protocols must specify how to identify the presence of an infection. The facility must use an infection assessment tool or algorithm for staff to follow to identify an infection. Whatever tool or system is used, the facility antibiotic protocols must include review of laboratory reports for susceptibility and whether there is a need to change the antibiotic. For example, whether it can be changed to one with a narrow spectrum. The Antibiotic Stewardship Program must include a system of reports to monitor antibiotic usage and organism resistance that is regularly shared with the prescription providers. It should also include how it will assess antibiotic use in your facility. Here is an example of severity level 2, noncompliance, where no actual harm comes to a resident. However, there is a potential for more than minimum harm, but not immediate jeopardy. The facility failed to implement its protocol for antibiotic use and failed to monitor actual antibiotic use. Record review indicated that the facility developed a protocol which indicated residents with multi-drug resistant organisms, MDROs, are not to be treated with antibiotic for colonization. However, record review revealed one resident colonized with an MDRO receiving an antibiotic to eliminate colonization. As a result, the potential existed for residents to develop additional antibiotic resistance. On March 16, 2018, CMS released a CMS Quality, Safety, and Oversight Memorandum discussing the need for at least part-time trained infection preventists. More information on these requirements, as well as training opportunities developed by the CDC and CMS, will be available in the spring of 2019. Tag F883 corresponds to the old tag F334. Facility policies must be updated based on best practices specified by the Advisory Council of Immunization Practices. This includes influenza and pneumococcal conjugate vaccine, PCV13, in addition to pneumococcal polysaccharide vaccine, PPSV23. Surveyors will review documentation of resident vaccine dates, education, refusal, risk and benefits, and contraindications. Key elements of noncompliance under F883 include failing to develop policy and procedure addressing the new guidance, failure to maintain or follow new guidelines, failure to vaccinate an eligible resident or document why it was not given, or refusing to allow a resident or resident representative to refuse vaccination. An example of severity level 3 citation is shown here. A resident who was not eligible to receive the influenza vaccine due to medical contradictions received the vaccine and experienced a reaction that was not serious or life-threatening, hives and dizziness. The reaction resulted in fear and anxiety that was not to the level of panic or immobilization, but required treatment. The resources I've referenced and referred you to or shared during this presentation are all available online. These websites can be helpful for facility staff to better understand and prepare for the CMS survey process.
Thank you, Pam. Although the format of the ICAR assessment is significantly different when compared to the survey process, we have both seen similar infection prevention program components that could be improved. Jessica, will you please continue the webinar?
Thank you, Carol. So as we had mentioned earlier, the ICAR team is a multidisciplinary team comprised of 3 certified infection preventionists with backgrounds in epi, microbiology, and nursing. This team partners with healthcare facilities that volunteer for an ICAR assessment. Each facility is provided with best practice recommendations, resources, and guidance with the goal of improving infection prevention knowledge in New Jersey and contributing to the reduction of healthcare-associated infections. ICAR assessments typically take 4 hours and include a guided discussion using the ICAR tool, a facility walkthrough, and if possible, observations of staff practice. Following the assessment, facilities receive a tailored summary by domain that shares best practice recommendations, guidance, and resources to mitigate identified gaps. The ICAR tool is a CDC-developed standardized questionnaire that is setting-specific. The long-term care tool has 9 domains: infection control program and infrastructure, healthcare personnel and resident safety, surveillance and disease reporting, hand hygiene, personal protective equipment, respiratory cough etiquette, antibiotic stewardship, injection safety and point of care testing, and environmental cleaning. The ICAR tool asks questions about policy, competency-based training, and auditing of each of these domains. Competency-based training programs and auditing are 2 identified opportunities for improvement across various domains. Competent is also a word you will come across in the new CMS conditions of participation. Staffing should be sufficient and consist of qualified, competent staff to meet residents' needs. CDC provides definitions for infection prevention competency. Competency is competency-based training, competency assessment, audit, and feedback are all defined by CDC. When the ICAR team asks about competency, we are looking for the proven ability to apply essential knowledge, skills, and abilities to prevent the transmission of pathogens during the provision of care. Therefore, a competency assessment ideally includes knowledge-based testing and direct observation of skill. Staff should be audited on a routine basis to ensure adherence to job-specific infection prevention measures. Audits should include documentation and feedback to staff using these findings to target performance improvement initiatives. The ICAR team has observed the largest opportunities for improvement in the personal protective equipment, antibiotic stewardship, and hand hygiene domains. PPE was identified by PAM as a tag issued on survey in relation to transmission-based precautions. For the 59 assessed facilities, 53% did not have a training program for new staff upon hire, including competency validation or proper use such as donning and doffing of PPE. Similarly, 57% did not have job-specific training and observed competency annually, while 80% of these facilities did not routinely audit PPE use. A common question or concern identified on ICAR assessments included the different types of transmission-based precautions and specified PPE. The ICAR team would like to emphasize that any direct resident care staff should be empowered to practice standard precautions. Standard precautions may include all available PPE based on the level of care being provided. The CDC's 2007 Guidelines for Isolation Precautions identifies the type and duration of precautions recommended for selected infections or conditions depicted on the right of the slide. The CDC also offers basic infection control information, including standard and transmission-based precautions, resident placement, PPE use, and other restrictions as appropriate. Refer to the links at the bottom of the slide for additional information. Here are some PPE resources that are shared with ICAR participants, including infographics, competency-based training checklists, toolkits, and fact sheets. The second largest gap was noted in the antibiotic stewardship domain during our assessments. The majority of facilities assessed were prior to the November 2017 deadline. The ICAR team asks questions that mimic the CDC core elements of antibiotic stewardship in nursing homes. Since Phase 2 implementation, we have seen stronger antibiotic programs in place. One of the greater changes for long-term care facilities involved establishing an antibiotic stewardship program with strong administrative support. Facilities assessed by the ICAR team identified gaps with written policies about antibiotic prescribing, practices to improve antibiotic use, providing feedback to clinical prescribers, and training nursing staff and providers on proper antibiotic usage. A common trend ICAR has noticed is that the infection preventionist being the leader of the antibiotic stewardship program. We want to highlight the CDC core element accountability and bring attention to the role of the medical director, director of nursing, and consultant pharmacist. Antibiotic stewardship programs require individuals with prescribing expertise. Nursing also plays an important role in assessing, monitoring, and communicating resident changes to the prescribers. The ICAR team created targeted educational opportunities to mitigate these gaps. In September of 2017, in anticipation of the CMS Conditions of Participation Phase 2 implementation date, the ICAR team held an antibiotic stewardship webinar discussing the ICAR team identified opportunities for improvement and featured 3 long-term care facility partners who shared their accomplishments, helpful resources, and how they got their program started. Here you will find the link to this ICAR webinar and resource list, including additional key resources applied by ICAR facilities. The third largest gap was within the hand hygiene domain. The ICAR assessment is looking that the facility policy aligns with the CDC's 2002 hand hygiene guideline, which promotes preferential use of alcohol-based hand rub over soap and water in most clinical situations. As Pam discussed, soap and water should be used when hands are visibly soiled and or caring for a patient with known or suspected C. difficile or norovirus during an outbreak, or if rates of C. difficile infection in the facility are persistently high. Through our assessments, we've seen that 78% of assessed facilities do not have policies that promote preferential use of alcohol-based hand rub in most clinical situations. It is likely that this is due to the older CMS language requiring hand washing, not hand hygiene, which hand hygiene is the language used most in the current CMS conditions of participation for nursing homes. This is a snippet of the 2002 guideline for hand hygiene in healthcare settings. A link to the guideline is provided on the bottom of the slide. Please note the recommendations. Of interest, number 1B. If hands are not visibly soiled, use an alcohol-based hand rub for routinely decontaminating hands and all other clinical situations described in items 1C through J. This is a CDC HCPAC Category 1A, which means it is strongly recommended for implementation and strongly supported by well-designed experimental, clinical, or epidemiological studies. The World Health Organization is another great resource for hand hygiene programs and includes frequently asked questions and posters to identify moments for hand hygiene during the course of resident care. This slide clarifies one of the common misconceptions, that is, healthcare workers can only use alcohol-based hand rub a certain number of times before hand washing is required. The healthcare worker's practice should align with the facility's policies and procedures. It is critical to note that the facility's policies and procedures, including hand hygiene, should be evidence-based, such as CDC's 2002 guidelines for hand hygiene in healthcare settings. Another common barrier healthcare facilities share with the ICAR team is that they cannot make the alcohol-based hand rub available due to vulnerable populations. CMS released a survey and certification group memo, historically referred to as an S&C, now Quality, Safety, and Oversight, back in 2006, noting the changes to language and that the requirement now states that, quote, dispensers are installed in a manner that adequately protects against inappropriate access. As Pam previously stated, it is up to the facility to make hand hygiene resources readily available and identify any potential risks. If you refer to the CMS Nursing Home Long-Term Care Survey Pathways, CMS-20054, Infection Prevention, Control, and Immunizations, you will see under the hand hygiene section that surveyors should be checking to see that alcohol-based hand rub is readily accessible and placed in appropriate locations, which may include entrances to residents' rooms, at the bedside, on your person, at workstations, and other convenient locations. The link to CMS where you can download these pathways is available at the bottom of the slide. In 2016, as ICAR was beginning to blossom, the CDC launched the Clean Hands Count campaign, which includes posters, infographics, and trainings for healthcare facilities to enhance hand hygiene adherence. This is a section for both healthcare personnel and patients and visitors. Here is a list of hand hygiene resources, including risk assessment tools for alcohol-based hand rub placement, posters, infographics, audit tools, and checklists. Other domains the ICAR team have identified as opportunities for improvement include injection safety, including point-of-care testing and environmental cleaning. Within each of these domains, there were gaps in competency-based training and auditing. As Pam discussed, poor practice in administering or preparing injections or taking a resident's blood glucose have resulted in immediate jeopardies for facilities. To mitigate this gap, the ICAR team developed and filmed 3 injection safety videos and created a facilitated discussion leader guide to help encourage staff engagement and discussion. The guide features questions and answers that facilitators can pose to staff after watching each video. These discussion questions were created to encourage staff to familiarize themselves with policy, proper practice, and to revisit policies to ensure they align with manufacturers' guidelines. The videos focus on proper glucometer use, cleaning of medication preparation areas, and safe injection practices. The guide, videos, and webinar are available on the CDS ICAR webpage, provided at the bottom of this slide. As a result of our work, the ICAR team has developed several other educational initiatives to increase infection prevention capacity in New Jersey. The team developed a guidance document to assist infection preventionists, both seasoned and novice, improve their practice by providing best practice recommendations and partnership opportunities. This document, entitled Guidance and Recommended Resources for Infection Prevention Partners, is filled with knowledge, resources, and tips to support infection prevention efforts across the continuum of care.
Thank you, Jessica. At this time, we'll review some of the questions that have been received. The first 3 are set up, Pam, so that you will answer them, okay? First question, are gloves permitted in the hallways?
Like alcohol sanitizers, the facility would need to assess the resident population of the hallway to determine if gloves can be safely stored and maintained by conducting a facility assessment and evaluating the services provided. They can determine why they want to store the gloves there and if there's a feasible place to store the gloves.
Thank you. Second question. Can a resident water pitcher go into the kitchen for ice refill?
One never knows where this pitcher may have been. It would be best not to bring anything that is personally used by the resident into the kitchen. It is not the best infection control practice.
Thank you. 3. Can I store anything under the sink?
Since the sink area is not described, I can only respond if it's in a resident's room or common area. Like alcohol sanitizers, the facility would need to assess the resident population of the sink in question to determine what can be safely stored and maintained. By conducting a facility assessment and evaluating the services provided, they can determine what they want to store under the sink and if it's feasible to store the item in question.
Thank you, Pam. Now we have a few long-term care questions for Jessica. There will be 6, Jess.
Okay.
Do you have a preference, or is there a CDC recommendation on the use of an alcohol-based hand sanitizer or a benzethonium chloride-based product?
So CDC recommends use of an alcohol-based hand rub as discussed in today's webinar. According to the CDC Show Me the Science page, many studies have found that sanitizers with an alcohol concentration between 60 and 95% are more effective at killing germs than those with a lower alcohol concentration or non-alcohol-based hand sanitizers.
Thank you. Now there's a question here about cardboard boxes. Can a facility store items in these boxes?
So storing items in corrugated cardboard is an infection prevention concern for various reasons. 1, cardboard is absorbent and cannot be cleaned and disinfected. And 2, storing items in shipping boxes can hinder an effective pest control program by harboring vermin and other pests.
Good. Next question. Are chest x-rays required routinely for staff that have had a positive tuberculin skin test?
No. A healthcare worker with a history of a positive tuberculin skin test or positive PPD should be screened annually for signs and symptoms of tuberculosis. If asymptomatic, no further evaluation is indicated. CDC clearly outlines frequently asked questions related to chest x-rays and screening at the following website: www.cdc.gov/TB/additional-FAQs.pdf.
Thank you. This is a double question. Is it okay to use the ICAR infection prevention assessment tool in place of an annual risk assessment? In other words, are there any facilities that you know of using this as a risk assessment tool?
So the ICAR tool is actually a great resource to routinely evaluate your current infection prevention and control program. However, it does not take the place of a formal risk assessment.
Thank you. Okay, next. Are individualized glucometers a requirement in long-term care?
No. However, according to CDC, whenever possible, blood glucose meters should be assigned to an individual person and not be shared. If the blood glucose meter must be shared, the device should be cleaned and disinfected after every use per manufacturer's instructions to prevent carryover of blood and infectious agents. If the manufacturer does not specify how the device should be cleaned and disinfected, then it should not be shared. Also, the device needs to be indicated for multi-patient use.
Okay, this one's about pill cutters. Are they single or multi-use items? And how do you clean them between use?
Ideally, medication should be provided in the appropriate dose, eliminating the need for that pill cutter. The American Society of Health System Pharmacists resource entitled Assuring Continuous Compliance with Joint Commission Standards, a Pharmacy Guide, inquires if drug preparation, packaging, and dispensing devices, for example, pill cutters, are cleaned after each use and disinfected if necessary. Also, that devices used for splitting tablets are cleaned immediately after use according to manufacturer's recommendations and instructions. So that's one resource you could refer to. Also, we would defer to the manufacturer's instructions for the actual pill cutter.
Oh, thank you very much for that. So at this time, we are going to conclude the webinar.